Ladies and gentlemen, it is my privilege to discuss a very important topic today. My thanks to the organizers for having me discuss such a upcoming and relevant topic. We are to discuss today non-renal indications for extracorporeal therapies. A couple of years ago, I was in Vizag discussing non-renal indications for peritoneal dialysis. And we had made actually a list of 12 of them, the 12 indications, many of them in which we ourselves had some experience using a peritoneal route. Today, the ICU patients that you and I manage are quite complex. If you look at this young man of 32-year-old, he had come to the hospital walking after toxic fumes inhalation in his factory, following which he went into lung injury, acute, and then sepsis, septic shock. You can see here, he is on ECMO, he is on CRRT, he is also on a filter called polymyxin for sepsis and sepsis treatment. So these type of complex patients need you and the intensivist together working 24/7 to bring them out of this complex situation. If I have to talk of the first indication which can be taken as a non-renal indication, I would draw your attention to congestive heart failure as a disease process wherein with or without renal failure, you may have to do a extracorporeal therapy to bring the patient out of the ICU and also improve the mortality. We published a few years ago ultrafiltration by peritoneal route in refractory congestive heart failure. And we found that when you do ultrafiltration by a membrane, which can remove these cytokines, collectively called as myocardial depressant factors, the outcomes of patients, both short-term and long-term, are extremely good. So we had looked in a subset of these patients, interleukin 1, interleukin 6, and TNF alpha measured both before the ultrafiltration was started and 4 weeks after the ultrafiltration was started. And we found there was a significant difference in the myocardial depressant factors in the circulation. We also found, to our surprise, change in hemoglobin levels, change in functional class of heart failure, change in number of hospitalization days, and also improvement in the LV ejection fraction. So we had concluded extracorporeal therapy, even though there is no renal indication in heart failure, was good. And the rationale for this was soft and gentle removal of fluid, less hemodynamic fluctuations, low maladaptive neurohormonal responses. What I mean by this is most of the heart failure patients already have a very active stimulated neurohormonal response or a sympathetic stimulation, whereas any drugs like diuretics worsen this, whereas ultrafiltration actually improves this. Also, as we just discussed, removal of cytokines and humoral factors leads to improvement in the outcomes of the patient. So we had these parameters looked at pre-ultrafiltration and post-ultrafiltration, and the ones that I mentioned, change in hemoglobin, ejection fraction, hospitalization days, and NYHA class were significantly different, as you can see the p-value here. So after we had started working on this in 2009, subsequent, there has been a lot of literature published in the world nephrology literature talking about inflammation as part of cardiorenal syndrome and removing these inflammatory mediators, improving the outcomes. So one of the modalities that is gaining coinage both in India and abroad is called as aquapheresis. And this is a gentleman, 68-year-old, who had COVID, improved, was shifted to a rehab, came back to us again with shock and breathlessness. We found that he was in sepsis, apart from heart failure, which was very severe, and serum albumin of 1.7 and hypokalemia. We had estimated that his fluid overload state was more than 10 liters. So after the initial 48 or 72 hours, and as his hypoxia was worsening, we decided to put this patient on aquapheresis because renal functions were okay. He did not need a solute clearance. So when I mean aquapheresis, it is done whenever there is a worsening heart failure secondary to LV dysfunction. And over the next 48 hours, this particular gentleman had 9 liters of ultrafiltration. I don't think I'll be able to play the video. So the Aquadex is something like this available today for us. It's a very simple interface. You can see to my right hand, the filter, which is a thin, slender filter, which has a membrane which can remove apart from wall data. This is something like a chemo filtration, but you don't even have to use a central line for this. You can use a peripheral line and you can get a lot of ultrafiltration. This patient was weaned off ventilator after the removal of the volume, and then he got discharged and went home. So in fluid overloaded heart failure patients, aquapheresis is available today, and as against the continuous renal replacement therapies, this is a modality in this subset of population. You can continue to use it for 72 hours or so. There is some Indian experience also, which is increasing both in Hyderabad and in Mumbai. I'm aware of several units using it. So there are a clinical need wherein you need to remove large volumes of liquid over a period of next 2 to 3 days in the ICU. This is a very good modality for us. I'll not go into the details as I already showed you the picture next to the patient. This is the interface and the filter that we talked about. So once this is used and the patient can be shifted out of the ICU faster and also goes home, and there is strong data to support that recurrent hospitalizations in heart failure patients with aquapheresis are significantly less, as I shared our own data with you. So there has been a suggested pathways to look at these patients and choose Aquadex when it is appropriate. The main thing here is not only in heart failure patients, anybody who has a significant fluid accumulation, the fluid accumulation itself can cause a drop in GFR, and you don't need any other reason to cause renal failure because the GFR drops just because of the interstitial pressure. And this is a cartoon all of us are familiar with. As the fluid overload increases, the net filtration pressure decreases across the glomerular capillary membrane and the patients can actually shut down. So we also now know the ultrafiltration rate has a bearing on the mortality, and the type of filter that you use and when you use and how much you remove also matters. So this is going to be a standard of care for heart failure patients as in the West, and some of the units are doing this as outpatient procedures wherein the patient can come and go after a episode or a session of aquapheresis. One of the things I already mentioned was reduction in neurohormonal stimulation, which is part of the pathophysiology of heart failure, which gets worse when you use diuretics and other modalities. Whereas with ultrafiltration or aquapheresis, this can be improved. And as I shared with you, 53% reduction in the risk of rehospitalization for heart failure. So the second indication where we have used some form of a extracorporeal therapy is ascitic fluid ultrafiltration. Cirrhosis, as you know, is an irreversible damage of the liver, and these patients present with refractory ascites, and the quality and quantity of life is extremely poor for these people. And again, the options of diuretics do not sustain because they will come with renal failure and dyselectrolytemia. Large volume paracentesis is not always possible, and when you do it more than 2 or 3 times, you can cause precipitating hepatic encephalopathy and infection in this group of patients. So we started using concentrated ascitic fluid, taking it through the dialyzer and a pump of hemodialysis, and we could get patients decongest their abdomens and remove large amounts of ascitic fluid using a regular hemodialysis machine and a polysulfone membrane, doing it on a weekly basis, at least one session. So we had used a Y connector to connect the PD catheter which was put in the patient's abdomen to the circuit of the hemodialysis machine. So what we found was blood pressures improved after this session, diuretic could be removed, the SGS scores improved, abdominal girth improved, weight improved by more than 10 kilos, hemoglobins improved, serum albumin improved, and then renal functions also improved. So what we actually did was we took patients and then put a PD catheter, connected the PD catheter using a Y connector to the hemodialysis circuit, and removed volume during this hemodialysis, but the blood was not running through the circuit, it was the ascitic fluid running through the circuit. So one of the comments was from the gastroenterology team, how do we know that we are removing this volume and the albumin that is going back into the circulation is actually staying all over the body and not only in the abdomen? So we actually radionuclide labeled this and then showed that after the initial few hours, the tracer was seen all over the body. So when you do ascitic fluid ultrafiltration, the albumin that you are allowing to stay back in the abdomen, because you are returning concentrated ascitic fluid back to the abdomen, the albumin does not stay within the abdominal compartment but goes into the circulation. So with this, the parameters that I shared with you do improve. So what is the advantage of ascitic fluid ultrafiltration? It avoids hypotension associated with large volume paracentesis. There is no loss of protein as with paracentesis because this volume concentrated ascitic fluid is returned back to the abdomen. There is no need for albumin infusion and it improves the quality of life. So we had several patients on this. This is a patient undergoing the therapy. As I can show you the PD catheter which is connected to the hemodialysis circuit and the ascitic fluid is in the circuit and you are able to remove large volumes of fluid. So we published this data and we failed to make the gastroenterologist accept this as one of the modalities for refractory ascites. But I believe it's a very useful tool, and in our patients in whom we tried, we found it improving their quantity and quality of life. So if you look at the literature today about extracorporeal blood purification in critical illness, there are a list of things that you can do, including coupled plasma filtration adsorption, hemoperfusions, various types, molecular adsorption recirculating system, plasma exchange. So all of them are in vogue, and for a good intensivist or a good nephrologist taking care of acute settings, the knowledge and know-how of all these is extremely important. So this particular paper, which I shared with you, talks of the disease condition and what you can do as an extracorporeal therapy. As you can see, acute kidney injury is just one of the indications, and there are so many non-renal indications, including sepsis, fulminant hepatic failure, diseases like TTP, HUS. You need to do plasma exchange in desensitization where you are not using it just for a solute removal. And then intoxications or poisonings wherein you can do a lot of these modalities to improve the patient outcomes. This is another paper from Spain, which talks of the approach to extracorporeal therapies. Though the initial discussion is about AKI, subsequently they do discuss about other indications for extracorporeal blood purification, and they have given a list of them. As I shared with you in the beginning, more than 10 different indications for non-renal indications for extracorporeal blood purification therapies. One of them they talk about in detail is HVHF, where to do it, how to do it, and what are the outcomes. Various filters, including the aquapheresis we discussed, the Prismaflex we discussed, all of them are discussed in detail, the surface area, blood volume, and then patient, where it can be used and what should be the volume. This is an interesting paper which you and I will connect to because many of us have managed patients in the COVID era. So this paper talks of effectiveness of extracorporeal blood purification in patients with corona disease or COVID-19. And they talk of how to do it and they just took 10 patients, allocated them into control group and no intervention group, and found that there was significant improvement when a filter was used even for a non-renal indication. You can see here the creatinine was only 1.2 or so. So this is the change in the oxygen saturation after the hemoperfusion according to this paper. And interestingly, from our own group, Dr. Vijay Verma has now compiled almost 54 patients or so in whom COVID patients, he has done the PMMA membrane with adsorption properties and found that the outcomes were significantly better. This data which I am showing you is from his unit, 49 patients, 37 males and 12 females, mean age of being 45 years. And then the indication was COVID positive patients, second week of illness, increasing oxygen requirement. Now, in all these patients, IL-6 was not looked at because one of the things we observed was there was no correlation between IL-6 level and the patient's clinical status. So the procedure was done as at least 2 sessions of Hemofil, and all these patients which I'm showing you now, none of them had renal failure. So this was a real non-renal indication for extracorporeal therapy. And out of the 49, around 24 of them survived. This is with people going on ventilators, and definitely it reduced their ICU stay. And I'm also aware of several other units which have done this filter in the COVID era with very good outcomes. We had our 2 transplant patients on whom we had done it. Both of them walked home after 2 sessions. So the last part, we should talk about the extracorporeal blood purification therapies for sepsis. There are close to 10 different extracorporeal therapies which are now accepted for sepsis and as a non-renal indication. The main reason for this is to remove pathogens from blood, remove endotoxins and PAMs, removing activated leukocytes and removing cytokine blood levels. I will not go into the details, but this paper I shared with you is from Ronco's unit, and they have talked of the mechanisms and the utility of using various filters for non-renal indication in sepsis and septic shock. So they do talk of the membrane, the first layer, second layer, third layer, and how each of these things, including endotoxin and the cytokines, are effectively removed. So with that, we will come to our end of the discussion. Extracorporeal therapies are here to stay, even in non-renal indications. As I shared, the common settings could be heart failure, COVID-19 or similar such illnesses, and then, of course, your septicemia per se, wherein even though renal failure is not there, these filters are used to improve the outcomes. Thank you very much for